Picture this. A doctor loses his license for sexually assaulting patients, then pops up in another province, white coat on, room full of brand new patients. No warning label, no flashing sign. Most of us would never know. Here's the thing. Today we're asking, how can that possibly happen? And, more importantly, how often does it happen? First, we'll zoom out from that one doctor to the bigger landscape. Then we'll walk through what a group of Canadian researchers uncovered when they tried to connect the dots. Finally, we'll talk about what clearer, louder transparency could look like for every patient sitting in an exam room, trusting. Section 1. The Jigsaw Puzzle. Think about trying to read a novel when the chapters are scattered across 3 different libraries. You find one chapter in a newspaper archive, another in a court database, and a third on a regulator's hard-to-navigate website. Each chapter is true on its own, but none of them give you the whole plot. That's exactly what the researchers faced. So they treated each source, news reports, court rulings, and disciplinary notices, like separate puzzle pieces. By cross-checking names, dates, and outcomes, they built a fuller coastline, revealing hidden coves the official maps had missed. What they saw was bigger and murkier than anyone expected, more victims than formal records showed, and more physicians still practicing than patients would ever guess. Let that sink in for a second. Section 2. Numbers with Faces. When the team layered the datasets together, scale was the first shock. Formal regulatory notices hinted at a handful of harmed patients. Add court documents and media coverage, the number multiplied. We're talking women, girls, and yes, at least dozens of children. And these aren't dusty, long-ago files. Some of the doctors with proven findings of sexual misconduct are still in practice today. New city, fresh waiting room, same history. Why certain specialties? Family medicine and psychiatry popped up most. Not because those fields are riskier by nature, but because they hinge on long-term trust, intimate conversations, and physical exams. That trust can heal, or it can be twisted. Section 3. The Long, Broken Timeline. Let's time travel through a typical case. Complaint filed, clock starts. Years pass. Hearings postponed. Maybe there's a quiet hospital review, maybe a criminal charge. All while the doctor can move clinics or even cross provincial lines. Finally, a disciplinary decision lands, but the sanction is anything but standard. One doctor loses their license forever. Another gets a short suspension plus a mandatory course. A third keeps practicing under a cryptic, conditional license. The average patient reading that single paragraph, they'd never decode the backstory of boundary violations. Signpost here. The key problem isn't just punishment, it's opacity. There's no single, plain language, nationwide database that tells the whole story in one click. Section 4. The Iceberg We Can't See. Now, follow me down another hallway. A hospital quietly pulls a doctor off call schedules. No explanation. An insurer notices long, counseling appointments with the same teenaged patient, makes a note, moves on. Staff whisper, boundary issues, but are warned to keep it down. None of those clues make it into the public datasets, yet together, they hint at a much larger iceberg below the surface. Civil lawsuits often settle with non-disclosure agreements, sealing any warning signs away from the next clinic or the next patient. So, remember, the cases we can see in this study? Almost certainly the floor, not the ceiling. Section 5. Rewiring the Safety Net. Here's where the research pivots from spotlight to blueprint. Imagine every disciplinary action, court ruling, or hospital restriction generating an automatic, itemized, plain English post online, like a receipt you can actually read. Journalists, advocates, hospital committees, they could connect patterns in real time, turning whispers into early warning systems instead of postmortems. That means clearer language, suspended for confirmed sexual misconduct, not practice limitation, shared reporting rules across provinces, and a seat at the table for patients' voices. Rewiring an old house without turning off the lights? Exactly. Careful work, but doable. Think for a moment about who needs to be in that room when we redesign the system. Clinicians, regulators, survivors, tech experts, community elders. Transparency isn't a memo, it's a group project. Section 6. Your personal checklist. Before next week, try these 3 reflections. 1. If a physician in your town had a proven history of sexual misconduct that no one told patients about, what would you feel morally compelled to do? Who would you call? How would you talk about it with friends or family? 2. In your own clinic, hospital, or community practice, where are the blind spots? Vague chaperone rules, fuzzy complaint pathways, hard-to-find licensing records. Pick one and raise it with leadership this week. Email counts. 3. Put yourself in the shoes of a patient who decides to report. What would make you feel safe? A clear online form? Trauma-informed staff? Public data on outcomes? Which of those pieces can you realistically push for right now? Exceptional recap. So, here's what we covered today. 1. The puzzle. Vital information about physician sexual misconduct is split across newsrooms, court files, and regulator sites, leaving patients in the dark. 2. The scale. When you stitch those fragments together, the number of victims, and doctors still practicing, jumps dramatically, with women, girls, and children most affected. 3. The opacity. Sanctions vary wildly, language is cryptic, and there's no single, national, plain English database. 4. The iceberg. Countless cases never surface because hospitals, insurers, and settlement agreements keep them buried. 5. The blueprint. Automatic, transparent, patient-friendly reporting can flip the script from after-the-fact outrage to early prevention, and every listener has a role in demanding it. Here's the empowering part. You can start today. Ask a question. Send an email. Share this episode with someone who sits on a hospital board, because sunlight isn't just a disinfectant, it's a deterrent. Thanks for listening. I'm Gim, and this has been Stay Curious, Stay Courageous, and we'll see you next time.